Good morning. First of all, I would like to thank Sri for inviting me to deliver this lecture. So today's lecture is going to be common injuries in badminton. Badminton is a very popular sport in Sri Lanka. The most popular sport in Sri Lanka is cricket, but apart from that, badminton also is within the first 5 ranked sports in Sri Lanka, and it is considered one of the fastest sports, racket sports. Though it's not a contact sport, though it's a individual and maybe double sports, there are a lot of injuries associated with badminton, but none of them are very serious. A lot of them can be due to overuse injury, but apart from that, there can be some acute injuries also. So since it's a very fast moving racket sport, it is associated with injuries, and the main reason for that one is because players require a large amount of stamina. Not only stamina, they need strength, they need speed, they need agility, where they are capable of moving around without any problems, and they are capable of moving within a short period of time, and they also should have a good coordination. So because of all these factors, it's a very fast game. They need not only the aerobic capacity, but also the strength, the agility, speed and coordination. This is associated with lot of injuries, and since it's a common sport also, there are a lot of people who are having injuries associated with acute or chronic overuse injuries. Badminton is played in as a single player or a double player or mixed doubles, but still it's a doubles type of a sport. So there's a slight difference between single player badminton and double player when they are playing as a double. So in a single player game where they need extraordinary physical capacity, normally it lasts for about 10 to 15 or maybe 20 minutes depending on the level of the players and the level of the opponent also. It can vary from 15 to 20 minutes. So during that period, in a single match, they need extraordinary physical capacity with quick movements around the court. But when it comes to doubles, it's a little different from that one. It's extremely fast again comparatively when compared with single player game. Double player game is little bit faster than the single player game, and in doubles there's lot of jumping and lot of smashes compared with the single player matches. It is said that around 50 to 60% of scoring is done using smashes in double games. So there is a slight difference between the single player and a double player game. In a single player, they need lot of stamina for about them to play for about 15 minutes to 20 minutes. They need lot of stamina, but in double player games, they need stamina as well as strength, and lot of jumping activities is involved. So these are the slight differences between single and double play badminton games. As I said initially, though it's not a contact sport, it is relatively associated with relatively increased amount of injuries, but none of them are very serious injuries. It's mainly because the badminton play is associated with lot of movements. They have to do lot of lunges where they have to go near the nets and do lot of lunges type of activities, and they have to change directions when they are playing in a one particular place. They have to change the direction from that place to another place quickly within a very short period of time. So those are also associated with injuries, and it involves a lot of jumping and landing, where when they want to smash, they jump up into the sky and they do the smash and they have to land. So not only lunges and changing directions, they have to do a lot of jumping activities also. And smashing is a completely different type of activity. Now this lunges, change in direction and jumping and landing all involves mainly the lower extremity where your legs are involved. But In smashing, it's the upper body or the upper limb or the arm which is more involved in smashing, and they had to change the directions very regularly also. So the injuries are associated with lower extremity where the lower limbs, and upper extremity with the upper limbs. And not only that one, their core, they have to have a very strong core, or the abdominal muscles, with the abdominal muscles. So they tend to have lower limb injuries, upper limb injuries, as well as the back pains. And as I said earlier, it is also associated with acute as well as overuse injury. Now they have done a study in around 2020. They have found out that most of the injuries in badminton are overuse injuries, not acute injuries. It does not mean that acute injuries are not there, but comparatively overuse injuries are much commoner in badminton than acute injuries. It is because lot of badminton players tend to do the same type of activities where they have to change the direction, jump up and smash. So those are the main injuries involved, and the lower limb and the upper limbs are involved. So apart from that, the amount of activity that they do during the badminton play is almost the similar. So that is why they tend to develop lot of overuse injuries than acute injuries. And the same study, they have found that the area where the players develop lot of injuries, we tend to think that since the badminton is played using their dominant hand, we tend to think that upper limb injuries or mainly the shoulder injuries are much commoner in badminton players than the other injuries. But according to these studies, they have found that lower leg injuries, the knee injuries as well as the ankle injuries are much more common in badminton players than upper limb injuries. Upper limb, when we consider upper limb injuries, they are almost always around the shoulder or the elbow joint. But when it comes to lower limb injuries, it is the knee and the ankle. But not only those two injuries, the back pains. Lot of players, when you see this study also, you can see that the back pain is as prevalent as the upper extremity injuries or the upper limb injuries in badminton players. Not to that standard, to that level. I mean, it might be slightly lower than the shoulder injuries or the upper limb injuries, but still it has a very high prevalence. So the majority of the injuries are in the lower limb, but true that they have upper limb or the shoulder injuries as well as the back injuries, back pains. Why do they develop these injuries? It is because mainly the overuse injuries are mainly because one reason is poor technique. Lot of badminton players, due to their poor technique, tend to develop overuse injuries. The other main reason is lack of exercise. Lack of exercise in the sense, now you might think that since badminton players are playing for a long period, they do a lot of exercise, they do a lot of physical activities. So why do I say that they lack exercise? It is because it is true that they go and play, but the amount of exercise, the amount of physical fitness they do in their practices, whether it's up to their standards, up to the requirement, that of course is a problem. Because when they exercise, they have to do the strength exercises, they have to do the endurance exercises. Maybe a lot of them practice doing strength and endurance exercises, but what they forget is about the agility exercises. They should have the ability to move from one position to another, and they should have the ability to change directions suddenly. So definitely they need to do lot of agility exercises also, and apart from that, they have to do lot of balance and coordination exercises. then only they can adapt, their bodies can adapt to whatever the requirements the game possesses on them. And when it comes to the techniques, poor techniques, suppose that the player goes to the back of the court, where not in front, where towards the net, but when they go back and they want to hit the shuttlecock to the back of the opponent. So it has a good technique where not only the shoulder but also the whole body, his back muscles, his lower legs, everything is involved. In this picture I have showed you that they have to bend knees slightly, their pelvis and the shoulders are angled somewhat slightly, and when they execute their shot, they should rotate their whole body, and the force transmission is properly transmitted to the upper limbs. Without doing that proper technique, without following this proper technique, if they tend to use their shoulder only to hit the shuttlecock back into the opponent's posterior side, then definitely they are going to develop a lot of injuries. So technique is a very, very important thing, and when they are doing their backhand playing also, normally what they do is they tend to use their wrist only. But if they can use their the force transmission using the whole body, then most of these injuries can be the chronic injuries, or the overuse injuries can be prevented. And when they practice, definitely they have to do strength practices. When they do strength practices, not only for the upper limb, they have to do it for the upper limbs, for the core muscles, as well as for the lower limbs. Then only they can meet whatever the requirements in this game. And endurance practices as well as the agility. Agility in the sense, there are techniques, there are ways of practicing how to improve their direction, how to improve the way they change their directions, how to do it quickly. So these exercises they have to practice during their practice sessions. And the other one is inadequate warm-up. Most of these players, when they come to us, when they come with injuries, when especially these young ones, when we ask from them, how do you warm up before a match or before a practice, a lot of them do not know. A lot of them do not know what the warm up means. So that is a huge issue, because when I ask them, when do you go to the court, what is the first thing you do? All of them say, we start by stretching our neck and the upper limbs, which is not the correct way. Initially what they should do is to do some kind of a warm up, where it can be jogging, it can be simple running, it can be jumping jack like activity, where their body is warmed up, so that their heart rate goes up, so that their breathing goes up, and all the joints are lubricated properly. Then after that one only they can do the stretching. When it comes to stretching, again there are two types of stretching: dynamic stretching and static stretching. During my presentation, where I'll tell you how to prevent these injuries, I will talk about this again. But when it comes to stretching, there are two types of stretching: dynamic stretching and static stretching. Dynamic stretching means you do the stretching while you are doing some amount of movement. You don't just hold the stretch like that. You do some amount of movement. With that movement only you do the stretching, which is called the dynamic stretching. And unfortunately, majority of our players do not know what dynamic stretching means. All of them know about the static stretching. So what they do is, during warm up, they do static stretching, which is a form of a cooling down process, which is not good for a warm up. Ideally what they should do is dynamic stretching, where they don't hold any amount of they can hold for about maybe 1 to 2 seconds, then they have to release that one and stretch it again. So repeatedly, if they do this kind of a dynamic stretching, they will be okay. A simple way, now a lot of people who do the sports know that butt kicks, which is a very good way of doing the static stretching for your quadriceps muscles. Likewise, if they can do proper static stretching before doing any kind of a sporting activity, that will be good for them to prevent developing any kind of injuries. And definitely overuse injuries, most of the time they don't get adequate rest after practices, and they don't have proper sleep after practices. So that, and they don't do the proper warm down also, or the cooling down also after the practices. That is one factor where they develop lot of overuse injuries. So we'll talk about individual injuries now. As I said initially, the commonest injuries are in the lower limb, and out of them ankle injuries are the commonest. In badminton players, when they play badminton, they tend to twist their ankles, as I have showed it in this picture, where when they have to play the shuttlecock near the net, they have to lean there. I hope that you can see my pointer. If you can't see the pointer, now in this lower down picture, can you see the player? Can you see the player trying to play the shuttlecock near the net, where all the force, all the power and the force comes front, but suddenly all that power goes into his ankle, because he just after playing the shot, he has to stop himself and go back again. So when the player puts their leg onto the front, they definitely have a higher chance of twisting the ankle. So when they twist, it is also mainly the inversion or the supination is the commonest type of injury, the commonest type of action, the movement which happens in the ankle joint. So I hope that you can remember there are medial and lateral ligaments around the ankle joint. So mainly on the lateral side, or on the outer side of the body, there are 3 ligaments: ATFL or the anterior talofibular ligament, CFL on the calcaneofibular ligament, and the posterior patellofemoral ligament. Talofibular ligament. So the commonest one is affected is the ATFL or anterior talofibular ligament. So in the history, they will always say that there was a twisting of ankle while they are landing, while they are playing, as I said, near the net, or it can happen when they jump to do a smash, and when they land again, they can land in an awkward position where their ankle goes into twisting. So definitely just after that incident, they will complain that they have pain in the lateral aspect of the ankle, and they will have some amount of pain while they are moving their ankle. Depending on the injury type, there is the ATFL type 1, type 2 or type 3. Type 1 in the sense there will be only a strain, small amount of strain is there. In type 2, at least about 50% of the ligament can be damaged, or in type 3, the complete ligament is torn. So depending on the type of injury, they might have different presenting complaints. Some people might say that they find it very difficult to bear weight on that leg after the injury. Some people say they have instability. So depending on that one, they might complain whether they have pain or instability. But during examination, what you can see is definitely there will be some amount of swelling just below the lateral malleolus, below and anterior to the lateral malleolus. There will be some amount of swelling, and patient invariably will have pain, and there will be point tenderness over the ATFL area just below and anterior to the lateral malleoli. And if you examine the talar tilt, which you use to do the ATFL, to assess the ATFL, if you do it in a slight plantar flex position, then definitely it will be painful. But all the other tests like squeeze test or the external rotation test, where you look for the AITFL, the syndesmosis of the joint, those will be normal. And functional test will be very difficult for them. Some if it is a grade 1 or mild injury, they might be able to walk on tiptoeing or walk on toes. But if it is a grade 2 or grade 3 type of injury, they will find it very difficult to walk on toes because of the pain. So these are the examination findings that you will find in a patient who is having a ATFL injury. How are we going to investigate a patient like that? Normally, X-rays are not needed, and if we are to do the X-rays, there won't be any finding in that X-ray. It will be, most of the time it will be normal. But for you to understand whether we should go for X-ray or not, we can use this Ottawa ankle or foot rule. In this picture, you can see that there are areas A, B, C and D. If they have any point tenderness over those areas, it is an indication to do an X-ray. And if they cannot bear weight, and if they cannot walk for about 4 steps bearing weight on that leg, it's an indication again to do the X-rays. So in my grade 1 or ATFL injuries, I don't think that you need to do any kind of a X-ray to find out whether this is a ATFL or not. Ultrasound is a very good investigation, which is the best available investigation for us to diagnose the ATFL injuries. So the radiologist will be able to tell whether this is a type 1, type 2 or a type 3 type of injury. But MRI is the gold standard, but we always will not be able to do MRI for these type of patients. But definitely ultrasound is a very good useful investigation to find out whether this is the type 1, type 2 or type 3 type of ATFL injury. Management wise might depend on several factors, but ideally whether it's a type 1, type 2 or type 3 injury, we can definitely manage them conservatively without going for any surgeries. But if this is a national player or a high-end player where they say that they need urgent recovery, then you might have to go for a surgical repair in grade 3 type of injury. But otherwise, it's almost always conservative management. But if you suspect and the ultrasound confirms that it's a type 3 injury, the player might have to be on a boot like this cam boot, where controlled ankle motion boot, where or a proper PRP for about at least 10 days then till they fully recover. But if not, if it is a type 1 or type 2 injury or even type 3 injuries, they can be managed conservatively without going for PRP also. But what we have to tell them is the management will be on stages: stage 1, stage 2, stage 3 and stage 4. Stage 1 is the initial management within first 24 to 72 hours, where our main goal is to reduce pain and reduce swelling and to maintain their range of motion as much as possible. So what we say is to go for the police regime in the initial acute phase. Police regime in the sense P means protection, OL means optimum loading, and I means ice, and C means compression, and E means elevation. You might be knowing that one. So during the stage 1, the first thing is to go for the police management and ask them to do the isometric contractions, where they contract their muscles around the ankle joint, but the joint does not move. It stays on the same place. Though the muscle contracts, there won't be any shortening or lengthening of the muscles. So that is a very good way of reducing their pain and keeping the muscles activated during the rehabilitation period. But when you do that, you have to make sure that you give them an idea about the pain scale, where 0 means they don't have any pain, 10 means they are having unbearable pain. So they have to scale that the amount of pain they have in that pain scale. What we tell them is to do these isometric contractions within 1 or 2 of the pain scale. Out of 10, 1 or 2. If they can do the isometric contraction within the pain scale 1 or 2, then definitely they are going to do a lot of good for their injury. But if they ignore that one, and if they go beyond 3 in pain scale, definitely it's not good for them, and it may cause further damage. So that is what we say optimal loading, where they give some amount of load to the joint, but within the pain scale 1 to 2. So these are the main things in the initial management. And once a player develops an ankle injury, they are more prone to develop ankle injuries within the next 6 months. So it is always better if we can advise them to wear at least an ankle guard or rigid tape, so that the chance of them developing having another ankle injury is less. And during the stage 2 or the subacute phase, we have to do the range of motions exercises as well as strengthening exercises all around the ankle joint: dorsiflexion, plantar flexion, inversion and eversion, again within the pain scale. But with time, the amount of activity that they can do will improve. So initially, if they cannot contract the muscles to their maximum level, with time they will be able to do that one. So we have to tell them during the subacute phase, they have to do the range of motion exercises as well as strengthening and balancing exercises. And in stage 3, they can go back to their normal day-to-day activities without any problem. And what we tell them is to go for the agility as well as balance exercises during that period also. And stage 4, when it comes to stage 4, it's return to play. In return to play, what you have to understand is playing is not equal to going and playing a match. Competition is a completely different thing. Going and doing practices is a completely different thing. So initially in stage 4, we have to let them gradually go back to whatever the tournaments. Initially they can go and play when they have go and do the practices when they have no pain when they do their day-to-day activities. But if they have any kind of a pain in that scale, it's more than 3 or 4, then of course they are still not fit enough to go back to return to play. If they have, when they are doing day-to-day activities, if they don't have that amount of pain, then of course they can go for the return to play and start doing some amount of practices. Mind you, now as I said, the duration of this rehabilitation will differ from player to player, whether it's a type 1 injury or a type 3 injury. It depends on player to player as well as their level of play also. And the second commonest injury in the lower limb is the meniscal injury. You know, there are 2 menisci in a knee joint, medial and lateral menisci. So when they play in a type of action where they have to do a lot of lunges, and I hope you can see, this is the best picture I could find in the internet. The lower picture where a lot of colored players are playing. Can you see the player with the black color one? So when he jumps up and play the shuttlecock, when he lands, the landing position of the leg becomes a very awkward position, where we normally tell it the point of no return. His foot is landed on the ground, but the knee is twisted while we are bearing the weight. So this is the most common type of injury where they develop meniscal injuries. So meniscal injuries also can vary from the type of meniscal injury can vary. If it is a mild injury, player might have a little bit of a pain and he would be able to continue playing without any issue, with some difficulty. But if it is a severe pain, severe injury, definitely they will have severe pain and they will not be able to continue playing. So depending on the injury, whether it's a mild injury or a severe injury, their symptoms might differ. But most of the time what they say is they don't develop swelling, or the knee just don't swell at the time of injury. What they say is maybe after 6 hours they develop swelling of the injury and then swelling of the knee joint, and there will be some amount of locking or clicking type of a sensation, where when they extend their knee or when they flex their knee, they find the knee joint is locked, or they find something is moving inside the knee joint. So that is again a indication that this player might be having a meniscal injury. And of course, because of the swelling, their range of movement of the knee joint might be affected. Some instances, some players cannot remember a particular event where they had an injury like this. What they say is, I have had a small amount of knee joint pain, and when I play, I don't have that normal stability of my leg, and after a play or a practice session, they find that their leg is swollen. So this also can be a presenting feature. So that of course indicates that it's not a major injury, but still there can be a meniscal injury. So during examination, we find that there will be some amount of fluid in the joint. It's not a huge amount, it can be a very small amount of fluid, where the swipe test might be positive. You will not be able to see any patellar tapping type of a effusion, because it's not a huge effusion, but the swipe test might be positive, and they will have limitation of their range of movements, especially the extension. They will not be able to extend fully. They will always keep the knee slightly bent, and some players might have joint line tenderness, where if the medial meniscus is involved, the medial joint line will be tender. If the lateral meniscus is involved, lateral joint line will be tender. And depending on the type of injury, whether it's a whether it's a acute trauma or whether it's just a twisting of the knee joint, there can be associated injuries like collateral ligament injuries. So those places also might have some amount of tenderness. And McMurray's test and Thesali test will be positive. So Thesali is also a form of a functional test, where you can ask the player to bear their weight on the affected limb and bend the knee for about 30 degrees and rotate their trunk fully. And when they rotate their trunk without rotating the foot, then they might have some amount of pain in the knee joint, which is called the Thesali test, which can be positive. Again, how are we going to investigate these patients? Again, the X-rays might not show any major features. We can go for the Ottawa knee rule to see whether we need to do any kind of X-rays. So if there are any positive findings, like the age is more than 55 and the patient is having local tenderness over the patella or the fibula head, and if the patient is unable to bend the knee more than 90 degrees at the time of the injury, and if the patient is not capable of bearing weight and walking for about 4 steps, then those are indications for a X-ray. But meniscal injury per se will not have any X-ray findings. Ultrasound, again, they might be able to say that some amount of fluid is there, but whether it's a meniscal injury, that the ultrasound will not be able to tell you properly. But MRI is the investigation of choice. MRI will say whether this is a complete tear, bucket handle type of tear, complex tear, those features the MRI will tell you. So the management will depend on several factors. One thing is the age of the player. If the player is a young player, a small player, young player, we tend to manage them conservatively because they have a good healing capacity. We don't have to go for any surgery. And level of the player. If again as a national player or high-end player, we might have to go for surgery because they need proper proper management of their meniscal injury, proper recovery of their meniscal injury. So we might have to go for repair of the meniscus and severity of the injury. If it is a bucket handle type of a tear where there's a locking of the knee joint, it can be immediate. We might have to go for immediate surgery. And there are several things that several factors that we can have an idea whether this is going to be a surgical management or a non-surgical management. If the symptoms develop after 24 hours where the player cannot remember a particular event where he had this kind of injury, then it's most of the time it can be a non-surgical management. And the patient is able to bear weight without any problem. He just complains of whenever I go and play, I have this pain and instability. Again, those are features of mild type of injury where we can manage them with conservative management. And mild swelling, he is having almost full range of motion, and during the last bit of end range he has pain. All these are features that these injuries can be managed conservatively. So again, stage 1 we normally do stage 1, stage 2, stage 3 and stage 4 type of management. Stage 1 we can ask them to do the police, the protection, optimal loading, ice, compression and elevation. And isometric knee extension exercises are very important. We tell them to extend the knee joint as much as possible and hold it for about 30 to 40 seconds, 10 repetitions and 3 sets. So doing that run, their full range can be obtained very quickly, but again within the pain limitations, where in that pain scale they don't go beyond 2 or 3. And depending on the player, either minimal or no weight bearing, because when you ask them to weight bear, the meniscal will get crushed between the bones, so the injury can be worsened. So it's always minimal or non-weight bearing in the initial stages. And stage 2, what we tell them is to increase their range of motion and increase their muscle strength, not by doing squat type of activities where the knee has to bear a lot of weights. What we tell them to do the strengthening exercises on a seated position from an extension machine or leg curls. They can do those type of strengthening exercises without bearing weight. In the stage 3, we go for the agility and balance as well as the strength, continuing the strength training and make sure that they have their full range of movement and full range of strength, full strength by the end of stage 3 before sending them to return to play. When they go back for the return to play, we have a very simple way of assessing whether the player is fit to return to play after a lower limb injury, either ankle injury or a knee injury. So if they have full range of motion, pain-free, full range of motion, that is one indication. And the other one, if they have their muscle strength 4 out of 5 or at least 90% of the strength compared with the other side. So that is the second parameter. And their psychological fitness, if they say that I am fit enough, then again that's an indication. There might be players who are having their full range of movement and full strength, but still psychologically they say I'm still not 100% doctor. So that is not an indication for them to go and start playing in the field. And the other important thing is that they should be able to perform functional test. Again, ideally, comparatively, 90% of the normal leg. If they can do a functional test for the lower limb, what we can ask them to is to do a single leg hop test. In this picture I have showed you, what we ask them to do is to do a single hop initially on the non-affected leg. So they have to land on the same leg without toppling over, they have to maintain their balance. So we measure the length. We can ask them to do about three repetitions, and we can take the maximum amount of length that he can jump without toppling over. So initially in the normal leg, then we can compare with that one with the affected leg. If he cannot do, if the player cannot jump up to the 90% of the normal leg, still he is not ready to go and start doing his ground activities. So this is one of the ways to see whether the player is fit enough to go and start playing. So those are the mainly lower limb injuries. Now we will talk about the upper limb injuries. The majority of them have shoulder pains. Most of the time, it's invariably 99% of the time it's a supraspinatus tendinopathy or tendinitis. It can be an acute injury, after an acute injury, or it can be an overuse injury where they have developed it for a long period of time. In an acute injury, after a smash or after a heavy workout, they might feel that their shoulder is painful, especially during their abduction or flexion, where they do activities above the shoulder level. They'll have pain. So this is because they are I think you can see the picture, the rotator cuff muscles, the supraspinatus, infraspinatus, teres spinae and subscapularis. Those muscles, there's the coracoacromial arch. Those rotator cuff muscles can get impinged between this coracoacromial arch. The coracoacromial arch is the coracoid process, acromial process, and the ligament, coracoacromial ligament, that is the coracoacromial arch. So those supraspinatus tendon can get impinged between the coracoacromial arch and the humeral head. So they will have lot of impingement like features. When you have supraspinatus tendinitis or tendinopathy, the tendon will be swollen. So the space between the coracoacromial arch and the the humeral head will be limited. So when they do any kind of activity above the head, they tend to develop this impingement injuries. And invariably, because of that one, they find it very difficult to do the day-to-day activities. So during the history, but they say it can be a sudden injury. They can develop this after sudden injury, or it can be a gradually developed shoulder pain. They will say that they have pain in doing some kind of a reaching activity, where they go for a book in a shell or any overhead activities. They find it very difficult to do the day-to-day activities like combing hair, and removing and putting on t-shirts will be very difficult. So most of the time they also can tell you that they have previous shoulder injuries in the past also. So those are the some pointing factors in the history. During examination, definitely their range of motion will be reduced. They find it very difficult to do the full abduction, so full adduction, and they will have scapular dyskinesia when they lift their upper limb, when they lift their shoulder like the upper limb like this. Not only the humerus, but their shoulder also goes up like this. So it's there will be dyskinesia, and Usually by palpating we will not be able to find any particular tender place in these patients, but impingement test like the painful arc and Job's test as well as the Hawking's test will be positive in these patients. And investigation wise we can always go for a X-ray, and in the X-ray AP view, true AP view and axillary inlet view we can get the supraspinous outlet view, we can take those views. In the true AP the acromia, the height between the acromion and the humeral head will be reduced. We can compare with the other side and see. Normally what we say is it has to be around 7 to 14 millimeters, but in a player with this type of injury the height between that acromion and the humeral head will be reduced. We can always compare with the other side. And in some players there can be some abnormalities of morphology of the acromial process or hooked or curved type of things. Those things also we can see in the X-rays. And one of the best investigations would be to go for a dynamic ultrasound. It's not just an ultrasound. You have to do the dynamic ultrasound where while the player is doing movement, the radiologist can see whether there is impingement or not. So which is a very good useful investigation in shoulder evaluations. And MRI is the best, and it's the investigation of choice for patients with rotator cuff injuries, and they will say whether this is a tendinopathy or tendinitis in MRI. So how do you manage? Again the same way, stage 1, stage 2, stage 1 acute injury, stage 2 subacute, stage 3 activities of daily living, and stage 4 return to play. In stage 1 we can again go back to the police type of regime, and in stage 2 we should always tell them to avoid the painful activities and do isometric external rotation activities, especially not only the external rotation but specially external rotation activities, which we should tell them external rotation, internal rotation and shoulder abduction and flexion movements also. In stage 3 we should tell them that eccentric exercise is a very important type of exercise in these type of injuries. Eccentric exercises in the sense they contract their muscle, but the muscle does not become shortened, the muscle become lengthened. Now in this picture I have showed you that what you have to the player has to do is to use their other limb, use the unaffected leg, the limb to do the external rotation movement, and while keeping the external rotation movement like this they can lower the upper limb slowly. This is true, this is an internal rotation movement, but when you do it very rhythmically, where with a control, when you keep your hand like this, I hope you can see my hand, when you keep your hand like this you don't need any internal rotation muscles to lower the arm like down, keep it down, lower the arm like this. It's the gravity which is doing this one. So if we control this movement, it is the external rotation muscle which is doing that one, not the internal muscles. So though the external rotator muscles are contracting, they are lengthening, which is called the eccentric contraction. So initially we can do without any weight, but with time they can have some amount of weight, use their opposite hand or the unaffected hand to do the external rotation or the concentric contraction and release it slowly like this. So they have this eccentric contraction. So that is one thing that you have to understand. So during stage 3 we can go for those eccentric contraction type of activities, and we should always teach them to have that glenohumeral rhythm, proper glenohumeral rhythm, and we should tell them whenever you do activities, especially the abduction type of activities, but what we tell them, keep your shoulder down, not to elevate the shoulder like this, keep your shoulder down and do the elevation, so that glenohumeral rhythm is maintained properly. And of course, at this when the player can do all the activities without any pain, then of course they can go for the return to play criteria in stage 4. So the return to play criteria still the same: pain-free range of motion and muscle strength at least 4 out of 5, and patient is psychologically ready, and normal functional test. This balance 5 test is a good way of assessing whether the patient is having a near normal functional test in their shoulder joint. So these are the main injuries in the shoulder. So when it comes to elbow, the main complaint is the lateral epicondylitis, or what we call tennis elbow. It is the commonest type of elbow injury in players, and this is due to poor technique, heavy rackets, and incorrect grip size. If the grip is too small or too large, then also they can develop this type of lateral epicondylitis. So most of the time it's a gradual type of a pain where they cannot recall any kind of a trauma, but some players might say this has aggravated by doing some form of activity, maybe painting, maybe hammering to something. So they will say that they have been having a small amount of pain, but after a heavy workload their pain has increased. So they will definitely have pain while gripping, when they try to grip something, unscrewing a bottle and unlocking a door lock. Those type of activities will be very painful for them, and this will be relieved by some amount of rest. So during examination, elbow joint range of movement will be almost the normal, and there can be tenderness over the lateral epicondyle, and there will be some amount of pain just distal to that lateral epicondyle also, and definitely they will have a reduced grip strength. And the Maltese test, which is the extension of the middle finger, when we ask them to extend their elbow fully and flex the wrist joint, and ask them to extend their middle finger, that will be very painful for them. And resisted movements of the wrist extension also will be painful. So by doing this examination, we can find out whether the player is having lateral epicondylitis or not. Investigations are usually not needed, but ultrasound scan is a very useful tool in a very experienced operator, where they can show you that there will be a lot of blood supply to that area. So we know that this is most probably a lateral epicondylitis. So though investigations are not needed, ultrasound can be a very useful investigation. How do we manage them? Again the same way, but 99% of the time this is a non-surgical management. Acute injury, we can go for the police, and in this this is a type of overuse injury with a tendinopathy. So again, what we encourage them to do is the eccentric type of a exercise, where in this in this photograph, the black arrow, where when you lift their wrist, it has to be done using the opposite hand, and lowering the wrist is done by the player. So the eccentric contraction will be there, and we can use this body blade, which is called it's a supination and pronation activity with controlled motion. This is one of the best exercises for the tennis elbow. We can also go for the physiotherapy, where digital ischemic pressure is applied, or muscle release. We can do that one also, and some literature say that we can go for the steroid injection, but as a sport physician we tend to avoid going for the steroid. We prefer giving PRP rather than going for the steroid. But definitely these are second line management. First line management always going for the eccentric type of exercise and stretching the forearm muscles, as well as controlled movement of the supination and pronation. We don't have this body blade in Sri Lanka. So what we can do is go for a hammer. If you can have a hammer and controlled supination and pronation motion using the affected limb, this is a very good exercise for them. Lot of players, lot of patients tend to have this wristband. True, it's good, it gives you some amount of pain relief, but it's just a pain relief. What it does is to make sure that the direction of force will be directed towards another direction. It does not alter the injury mechanism, or it does not cure the illness. So this is just a painkiller, pain relief method. If you have a particular important event, you can always use this wristband and go for that event, but try to avoid practicing using this wristband. Otherwise, you will end up worsening your condition. So this is about the lateral epicondylitis. So the other most common injury is the back pain. A lot of people tend to forget about this one. In badminton, as you can see in this picture, you have a lot of extension, lateral flexion, rotation, as well as the flexion of your trunk muscles. When you hit the shuttlecock from the posterior side of the court to the other side, other player's posterior side, then you have to have this motion. So there will be extension, lateral flexion, rotation, as well as the flexion of the core muscles. So because of that one, they tend to have back muscle injuries. Most of them say that they cannot remember any kind of a trauma, any kind of a event where they have developed this back pain. It's a gradual type of a pain. None of them, in badminton players, none of them complain that they have any neurology like radiating pain. They don't have any weakness. They don't have any night pains. So it's a muscular type of a pain, and they definitely don't have any night pain. And they say that they have little bit of a stiffness early in the morning, back stiffness, and when they do proper warm up, their pain goes down, not 100%, but at least to a certain degree their pain goes down. So this is a typical history of a badminton player with a back pain. And during examination, what we can see is they will say that they are having severe pain on flexion rather than on extension or lateral flexion, and they will definitely not have any neurological signs like numbness or weakness in their lower limbs, and no SLRT, sacroiliac joint will be normal, and when you palpate, their paraspinal muscles will be very tender and will be very tight. So these are the main examination findings you can find, but apart from that one, there will be no neurological signs in these patients. X-ray wise, X-ray or the investigations, we rarely need any kind of a investigation. But if the player complains of a acute trauma, and while doing examination you find that you could find a particular place in the midline with a tender point, then of course you might have to go for an X-ray. And the other instance is in a right hand badminton player, if they say that they have a left sided back pain, again you might have to consider doing at least going for an X-ray, though they don't have any neurology, to see any past fractures, past interarticularis fractures. So the best view would be to take a scotido, the left oblique view, where you can see this famous scotido's appearance, I don't know whether you can appreciate. There's a black line in this Scotty dog. So this is a past fracture. So if a right hand player, badminton player complains of left sided back pain, or a left hand badminton player complains of right sided back pain, you should always exclude the pars interarticularis fractures. And apart from that one, if you suspect any kind of a muscle injury where the player has had a acute type of a severe pain, back pain, while they are bending, if you suspect that this can be a muscle tear, you might have to go for a ultrasound scan. And if you see any neurological features while during examination or in their history, if they complain of any neurological findings, then we might have to go for a MRI. Otherwise, investigations are rarely needed. Management wise, in the acute stage, we can also always go for the police management, and please make sure that you give them adequate painkillers in the initial stages. Otherwise, this back pain can go into a chronic stage where they will have severe pain, unbearable pain. So at the initial stage, it's always preferable, after doing all the investigation, all the examination and ruling out any sinister injuries, it's, if you suspect that this is a muscular tightness, it's always better to give them adequate painkillers, and make sure that they do lot of muscle stretching activities as well as strengthening activities. Like stretching activities, you can go with the cat camel, open book type of exercises, and child pose, which are very good stretching exercises. And when they are pain free, we can ask them to do strengthening activities like anterior plank or Superman exercises, which are good for the back muscle strengthening. And how are we to prevent these injuries? So now I have discussed with you all the major most common injuries in badminton players. How are we going to prevent that one? One thing is, as I said initially, warm up, stretching and cool down. Make sure that you tell your patient that proper warm up has to be done before any practices. Warm up and dynamic stretching during the initial phase of their practices. And when they do dynamic stretching, make sure that whole body, not only the shoulder but the back muscles as well as lower limb muscles, are stretched properly before going for the practices. And after the exercises, make sure that they do proper cool down by doing static type of a stretching. In a static stretching, they have to hold their stretch at least for about 20 seconds. If it is less than 20 seconds, it's not going to be a proper static stretching. The muscle has to be relaxed. So the player has to make sure that when they stretch their muscle, the muscle is relaxed, and when they do the static stretching, they should hold that stretch for at least 20 seconds. And if they can do 3 or 4 repetitions for the same muscle group, that will be the best. And when they train, make sure that they do lot of training, strength training to their upper limb, lower limb and core muscles. When they do lot of agility training, they do speed training, they do the reaction time. Even when in badminton, they have to take decisions very quickly and do their actions very quickly. So their reaction time has to improve. So make sure that these players do proper training during their training sessions for the reaction, to improve their reaction time also. And they should have proper coordination. So make sure that they do exercises for their coordination and flexibility. They have to have full range of motion in their upper limb, their back muscles, back and the lower limbs also. So make sure that they have their full range of motion during their practices. Then only they can prevent developing injuries. And of course, the proper technique has to be taught by the coaches properly, so that they will not develop any overuse injuries while they play badminton. I hope that you could learn something out of my lecture, and these are my references for the lecture. Thank you very much for listening, and I am happy to answer if you have any questions.